Today I will speak about the anatomy of the meniscus and the different injury patterns. I'll go through the attachment, traumatic tear, degenerative tear and change, and some normal variant. So we'll start with as I mentioned, I will start with the meniscal anatomy. The menisci are fibrocartilaginous structures that attach to the tibia and accommodate the femur. The meniscus or the menisci has more fibrous tissue and less water content compared to a cartilage. The function of the menisci includes weight distribution, particularly the femur over the tibia. It also protects and reduces the wear of the hyaline cartilage, of the knee cartilage. It converts the tibial surface, tibia surface into shallow socket and acts like a shock absorber. It is composed of three main regions: the anterior horn, which you can see anteriorly, the body, and the posterior horn. In some authors, they call it anterior third, middle third, and posterior third. You can see that the blood supply is peripheral, and the rest of the menisci is avascular, and it mainly takes its blood or nutrition from the synovial fluid. The younger the patient or the younger the person, there will be more blood supply, and the older that this blood supply starts to become less and less. The menisci, as I mentioned, is mainly a fibrocartilage, so it has more fibrous tissue than water. That's why it appears in MRI, appears always black or signal void. Whatever the sequence is, whether it's PD, FAT, PD, or gradient, you can see always the menisci as a black rectangular structure because of its less water content as compared to the cartilage. The menisci is mainly attached to the tibia. So it is attached to the tibia and moved with the tibia. And this done achieved through what we call meniscal roots. There is two of them, the anterior and posterior. And the other tibial attachment is what we call the coronary ligaments or the meniscotibial ligaments. These are the main attachment of the menisci. It has femoral attachment, which is we call meniscofemoral ligaments, and also they are attached to each other, what we call the intermeniscal ligament. But both the femoral and intermeniscal ligament, whether it's transverse and oblique, has no role in stabilization of the meniscus. Until now, we don't know its function, but we have to know that they exist. We'll start with the main attachment of the meniscus, which we call meniscal roots. They fix the meniscus into the tibia, and they are central, and they prevent the outward displacement of the menisci. There is two sets of pair of them. One is anterior and posterior. The anterior one is inserts in the most anterior part of the tibia, and you can see it here in the coronal images. This is the anterior root of the lateral meniscus. This is the anterior root. And they are attached very close to the tibial spine. Posteriorly, there is another two, the posterior root, and you can see they are attached very close to the tibial spine of the knee. They slightly, because they're mainly fibrous and mainly ligamentous, that's why its appearance in MRI is slightly heterogeneous when compared to the meniscus itself. On the sagittal plane, because most of the routine MRIs is done as a routine oblique, sagittal oblique, so we can see them when we are going from medial and lateral. And the first, if we scrolling through the MRI images from medial and lateral, the first root we're going to see is the posterior root of the medial meniscus. And because it's oblique, so you can see here in this sagittal oblique, you can see the meniscus anterior horn, but posteriorly, you can see the root. And you can tell the difference because you can see that the meniscus is signal void, is black, and the other one is heterogeneous with a little bit dotted. And you can see always the root is seen in front of the PCL. If you move central, we're going to come across the two roots, the anterior. So this is the anterior root of the medial meniscus, and this would be the posterior root of the lateral meniscus. And just always need to be careful about that, because when we do sagittal, it's always sagittal oblique. When we move further lateral, we're going to see the anterior roots of the lateral meniscus and the posterior meniscus of the posterior horn of lateral meniscus. And again, it's very important, and please don't confuse this heterogeneous appearance as meniscal tear or meniscal contusion. This is a normal root. That's why it's always wise and prudent that whenever you're looking at the sagittal MRI, to look where are you exactly in the coronal or sagittal plane, to make sure that you're not overcalling a tear, and this represents a root, not a tear. On the sagittal and the axial plane, you can see all different roots. You can see here the posterior root, and you can see it's different signal than the horn itself. And also sometimes you can come across the intermeniscal ligament, and you can see they're different. They have different attachment in the root. The attachment of the root is central, and but the intermeniscal ligament is seen anteriorly, and it connects the horns of the medial and lateral meniscus. So the intermeniscal ligaments, as I mentioned, they can be anterior or transverse or oblique. And you can see here, this is two different examples of anterior intermeniscal ligament connect to the anterior horn of both menisci. And you can see here the oblique intermeniscal ligament that connects the anterior horn to the posterior horn of different menisci. And till now, there is no known role of these intermeniscal ligaments, and they play less role in stabilization of the menisci. But for you, you need to know that this exists, and not to be confused with a displaced meniscal fragment. And I will show you examples of this later. The next important attachment of the meniscus to the tibia is what we call the meniscotibial ligaments. They have another name. They're called coronary ligaments, and the reason why they're called coronary, because they are circumferential. They are all around the menisci and tibia as a corona, so they are circumferential, not just medial and lateral. The meniscotibial ligament, as I mentioned, circumferential, so they expect to see them in the lateral side as a short, thin ligament. So you can also see it in the medial side, and also you can see it as in the posterior side. The meniscotibial ligaments are short and thin, so that's why they are not really seen in regularly in a normal MRI of the knee. Sometimes you struggle to see them. If there is some fluid like this examples in the knee, you probably will be able to see a normal meniscotibial ligament. It's very important to know that the meniscofemoral ligament medially, in the medial side of the knee, it actually represents the deep part of the MCL. And they have different attachments. They can directly attach to the femoral condyle, like this example. They can merge with the superficial part of the MCL, or they can have their own attachment into the femoral condyle. So they have the different and variant attachment, and not to be confused with any abnormality in this area. Again, as I mentioned, any femoral attachment of the menisci has less role in stabilization of the menisci. This is different than the most popular ones that we all know about, that's seen posteriorly in the knee, that attach to the posterior horn of the lateral meniscus. This is also called meniscofemoral ligament. So meniscofemoral ligament can be medially or posterior. And the posterior one, they have two different types. One seen anterior to the PCL, and we can call it the ligament of Humphrey. And the other one can be located posterior to the PCL, and it's called ligament of Risberg. And in the sagittal coronal plane, they can easily be identified. One of the rare ligaments that is not commonly seen in all normal patients or normal people, only less than 5%, is the anterior meniscofemoral ligament. And if you come across it, or patient have it as a normal variant, or you're going to see it's very close to the ACL and have the same course. But the difference is you can tell that the ACL is inserted in tibial, anterior tibial spine, but the other anterior meniscofemoral ligament is attached to the anterior horn of the menisci. And the importance of this is to know about it and not to be confused or overcall ACL tears. It's just by simply following this ligament, you will know what we are dealing is and what we are looking at, whether this is a ACL tear or just a simple anterior meniscofemoral ligament. Again, we don't have, there is no known role for this type of ligaments. It's just to know that this can exist, and sometimes it can be confusing. Okay, so now we'll move on to the most common pathology of the menisci, which is the meniscal tear. Broadly speaking, meniscal tear can be divided into three main types. Horizontal, which is the tear is done through the horizontal plane, axial I mean, and almost always they are associated with a component that goes to either to the inferior or posterior joint line. So they are not really true horizontal. They are called horizontal, but they are actually oblique because they always have this oblique component. The next common is the vertical, and it depends on whether this vertical tear is seen in the coronal or sagittal plane. So if it is seen in the coronal plane, if it's done in the coronal plane, i.e. perpendicular to the menisci, this vertical tear is called radial. If they are done sagittal plane through the long axis of the menisci, they are called also vertical, but they are called circumferential. And one of the most common variant of vertical circumferential is the bucket handle tear. And this is just represent a long or big, large tear of the vertical tear. And you can see here, it can be displaced. If the menisci have two components, horizontal and vertical tear, they are called complex. And sometimes this complex tear can have a displaced fragment and what we call a flap tear or displaced circumferential tear, like this patient. So this is the main three meniscal tear: horizontal, vertical, and complex tear. Generally speaking, vertical tear or complex tear are traumatic, and horizontal tear are degenerative. So this is just in general terms, but of course there is some exceptions. The most common scenario we see the vertical tear when it is associated with the acute ACL tear. And it's because an impaction injury on the posterior horn of the lateral meniscus or medial meniscus by the femur. So the femur hit the back of the knee and cause vertical tear of the menisci, like this example. And this is, as I mentioned, is most commonly associated with the pivot shift type of injury that causes acute ACL tear and posterior horn tear of the vertical tear of the posterior horn of the lateral meniscus. The other type of vertical tear, when it is circumferential, going through the longitudinal axis of the menisci, like this example, and this is just to show you how you expect to see this tear, just going through the course of the menisci. Sometimes they are represented like this, non-displaced, and sometimes they are this fragment can be displaced. And the most commonly seen with acute injury is the bucket handle tear, which basically it's represent a longitudinal circumferential tear with displacement fragment into the intercondylar notch. And those people represent to the A&E or to the orthopedic knee surgeons by having a true locked knee, because this meniscal fragment prevent movement of the knee. It's easily seen in the coronal, and you can see here in this example that the menisci, the median meniscus, is whole body is attenuated, and you can see there is another fragment which is being displaced into the intercondylar notch. The bucket handle tear is commonly seen in the medial side rather than the lateral, because there is more space in the medial side for the fragment to be displaced. In the sagittal, the fragment is displaced in the intercondylar notch, and you have this common or the most the popular sign, what we call the double PCL sign, where you can see the PCL, and in front of the PCL you can see the displaced meniscal fragment. And this is something we can see, as I mentioned, in the medial menisci. This is another example of bucket handle tear. You can see attenuation of the median meniscus. You can see displaced fragment in the intercondylar notch. And on the axial plane, you can see that the meniscal fragment has been displaced and looks like the bucket handle. Another example, you can see here in this instance that the whole of the posterior horn has been displaced into the intercondylar notch and caused locked knee. This patient is presented with locked knee. Bucket handle is more common in the medial meniscus, but if it is occur in the lateral meniscus, they are more likely to be displaced anteriorly. And this is an example of that. You can see here the posterior horn of the medial meniscus is very attenuated. This is what's left. And the meniscal fragment has been displaced anteriorly in front of the anterior horn of the lateral meniscus. And you can see here, if they are sitting very close to each other, they can produce what we call the pseudo hypertrophy sign, which actually represent a bone meniscal fragment sitting in front of the anterior horn. If you move slightly medially, you're going to see the rest of the meniscal fragment. So this is the main difference. If the bucket handle tear happen in the lateral menisci, more likely the fragment will move anteriorly in the intercondylar notch. If it's happened medially, the fragment will move posterior into the intercondylar notch. Other type, which is we call the flap tear, which is a variant of vertical tear. And this instance, the fragment is there is a tear, and the fragment is flipped. And this is something we commonly miss because we don't see much on the coronal, and you have to be careful to look for any meniscal fragment like this patient if you're not aware of this type of injuries, like this example. You can see here the most probably the tear happened there, but we don't see the tear itself. All you can see is the flipped meniscal fragment. Again, this is the same patient, but in the sagittal plane, you don't really necessarily see the tear itself, but you see the flipped meniscal fragment like that. Another example of a flipped meniscal fragment, but you can see here in this instance that the flipped fragment is larger than the meniscus itself, because and you can see here the flipped meniscal fragment is very large and it's located into the intercondylar notch. And all this type of injury can cause locked knee. Not always the flipped fragment can happen into the intercondylar notch. The fragment can flip laterally, like this, away from or medially away from the intercondylar notch. Like this patient, you can see here, the menisci is completely displaced, and you can see the fragment is seen in the medial gutter of the knee, deep to the MCL, and this can be superior or can be inferior. Sometimes the fragment is completely displaced not attached to the tendon or attached with a very small attachment like this patient. You can see the tear is here and the flip fragment is seen in the medial gutter. And on the axial images, you can see the structure, which could represent a completely displaced meniscal fragment. So we have to be careful because, again, this can be called only vertical tear, and someone with less experience can miss this displaced fragment. And of course, it's very important because if this patient were going to do any arthroscopy, this fragment need to be dealt with, either to get out or reattached to the menisci. The other type of vertical tear is the radial tear. And as I mentioned in the previous slide, it's when the tear is seen perpendicular on the axis of the menisci itself. And this is sometimes difficult to be identified, especially in the coronal images. And you can see here an example of that. You can see here the lateral meniscus of a normal triangular shape, but this is slightly rounded. And what happened is, in this instance, that a tear that occurred in the free edge or the inner part of the body of the menisci. And this type of injury is easily more seen in the sagittal plane rather than the coronal plane, because when you're going through the sagittal plane, you're going to see this kind of defect seen in the body of the menisci. So it's more easily seen on the sagittal plane. This is one of the most difficult injuries that's sometimes missed, which is the meniscal root tear. And that's why it's very important to know about it. This is an example of that. It is a vertical tear that happened at the junction between the root and the posterior horn. And you can see here, there's a tear there. And when we go through this type of injury in the sagittal plane, the place of the menisci will be replaced by hematoma and edema. And sometimes in some authors, they call it a ghost menisci. So if you go through the menisci in the sagittal plane like that. The other thing you need to know, because if the tear vertical happened here, the attachment of the menisci is lost. So that means it's easily for the meniscus to be displaced out of the joint margin, like in this patient, you can see. Another example of meniscal root tear, which again is commonly missed in the less experienced radiologist. This patient, you can see, had an acute injury with an impaction fracture of his posterior tibial spine. And you can see here that the medial meniscus is intact with the root intact. But if you look at the lateral meniscus, you can see it's suddenly blunted here. And you cannot see its root. You can see this is the root here of the medial, but you cannot see the root of the lateral. So because the root of the lateral horn or posterior horn has been torn. So you have to be careful about this type of injuries and not to miss them, because this patient can be presented later with instability of the menisci. Okay. Another type of vertical tear that can happen in the peripheral aspect of the menisci is the one associated with MCL injury. As I told you in the early slides, that the menisci is attached to the femur and tibia through the meniscotibial and meniscofemoral ligament. So sometimes there's kind of avulsion injury can happen, and this ligament is torn and avulsed from its meniscal attachment, like this patient. You can see here that this is the meniscofemoral ligament, and it's not attached anymore to the medial meniscus, and you can see that. And this one represents one of the meniscofemoral, meniscocapsular separation. And this is sometimes we can associate it. The good news is this is peripheral. It happens, if it happens in young patient, this is the vascular part of the menisci, and they can heal by itself. So it is not a surgical type of injury, but you need to know about it and call it whenever you see it. Another type of injuries seen with MCL when again the meniscal ligament injury is torn, like this patient, the meniscotibial ligament is torn, and actually there is what happened is an avulsion injury. So that means the whole of the tibial injury, tibial attachment of the menisci is torn, and the menisci can be displaced. And if this is associated with meniscal root injury, the whole menisci can go out of the joint space, like this patient, and this is what we call the floating menisci. And actually, the floating menisci is not injury to the substance of the meniscus itself. It's actually injury to its tibial and tibial attachment, whether it is the root and the tibial attachment. And this can happen with a severe medial knee injury. And you can see here that the meniscotibial ligament is torn, and the whole of the menisci has been displaced medially. And this is good news for most of the patients, because the knee surgeon can just simply put the menisci back in its place and repair it. One of the pitfalls that you need to be aware of and not to overcall meniscal injuries is the attachment of the posterior horn with the mediofemoral ligament. You can see, and this is mainly done in sagittal plane. So if you're going through a knee MRI and you see this line between the root posteriorly and the posterior horn, you need to check where are you exactly. Because if you see yourself that you are at the junction between the posterior horn and the meniscofemoral ligament, so most probably this is not a true tear. This is just the junction, and that's why it looks heterogeneous like that. So this is not a true tear. So a tear, what you expect to see it further in the meniscal posterior horn itself. So this can lead to overcall of a meniscal tear in normal patient. Another pitfall that you need to be aware about is when the popliteus tendon is seen in very close to the posterior horn of the lateral meniscus. You can see this line, and there is a very small, thin recess, and some people can easily mistake this for a tear. And you can see that the coronal, this is not a tear, this is just between the junction between the popliteus tendon and the posterior horn of the medial meniscus. And again, that's why it's very important when you're looking at the menisci, you have to do it on an opaque screen and always compare and correlate between the sagittal and coronal images and also the axial images to know exactly where are you and not to overcall any meniscal tears. The other types of injuries is the horizontal tear, and as I mentioned, horizontal tear is generally speaking are more likely to be degenerative, and they almost always have an oblique component. They can have also develop a meniscal cyst, and the meniscal cyst can be projected posteriorly, medially, or laterally, or even can be projected into the meniscal substance itself, like this patient. They can become large, and they can happen anywhere, medially, laterally, posteriorly. And we can see in this patient there's a sizable meniscal tear seen in projected from the anterior horn of the lateral meniscus. And you can see they can grow up and be very represented with a very large mass or cyst in either medial or lateral side of the knee. And always the clue is to follow the meniscal cyst itself and see if there is any communication with the menisci and if there is any meniscal tear, because meniscal cyst has to be associated with horizontal or complex meniscal tear. One of the normal variants, anatomical variants of the meniscus is what we call discoid meniscus, and it is called discoid because the whole meniscal substance covers the tibial condyle. As you can see, a normal meniscus does not cover the most of the condyle, only the peripheral aspect of it. But when it covers the whole of the menisci, like this patient, it is called discoid meniscus. It's most of the time is not problematic, but can lead at some point to a degenerative tear because of the continuous stress, especially on the inner part. 90% of the discoid meniscus occurs in the lateral side, but can also happen for 5% can happen in the medial side. I can see this is an example of lateral discoid meniscus with a horizontal tear and a small cyst. And this is another example of the more less common type of discoid meniscus. You can see here in this instance, the discoid meniscus is seen medially and not laterally. And those patients presented when they have a degenerative tear and or cyst formation, like this patient. So in summary, in this presentation, we showed the anatomy of the menisci and its attachment. The most important type of attachment is the tibial attachment and the roots. The femoral and the intermeniscal attachment are not important and does not have any role with the meniscal attachment. I showed you some examples of acute meniscal tear, which is mainly vertical, and displaced vertical causing locked knee, especially when they are bucket handle or flipped, and a degenerative meniscal tear, which is mainly horizontal and associated with meniscal cyst. And thank you very much.